Good evening, friends. Welcome back to Weekend with a Maestro program. This is ninth episode of Weekend with a Maestro program. We had a successful run of eight programs, and thank you very much for being with us again. Today we have yet another important topic, that is optic nerve decompression. Thank you very much, Fine, for being with us at all. With being with us this evening, and some meeting etiquette to follow. Please mute your audio to start with so that we do not have any disturbances during the program. And if you have queries at any moment of the presentation by me as or by the speaker, by the faculty, please raise your hand. We will stop then and there and clarify your date. And please use the chat box for asking questions. You can either message me or the faculty directly if you have any queries. Anyway, we are going to have a final discussion at the end where we can clarify all the doubts from our beloved faculty. Okay, and to start with, we don't have any financial conflict interests as far as this program concerned, and our sponsors are Basaveshwara Medical College and Hospital, Chitradurga, where I'm professor, and my personal entrepreneurship, that is Karnataka ENT Hospital and its a center in Chitradurga, and our not-for-profit organization, Champions Educational and Medical Society, Chitradurga. Okay, friends, next weekend with the episode that is being held on next Sunday, that is on 13th March 2022. So we have a topic on external rhinoplasty that is being done for crooked nose deformity. So I invite you all in advance to be there for that program. Very interesting program that will be. And with this, friends, I hereby invite our this week's Maestro. I haven't met him personally yet, but I am a deep admirer and I'm very proud of him. I welcome Dr. Vivek Sasindran, Professor Vivek Sasindran from Pushpagiri Medical College, Tiruvalla. I have been following him up on the online and various conferences, courses, and webinars. I found him one of the brilliant brains or brilliant ENT surgeons of our country. Hope one day I'll be able to meet him personally. Invite him for our program physically here at our Karnataka ENT Hospital at Basaveshwara Medical College. Dr. Vivek, welcome, sir. Are you there?
Thank you so much, sir.
Yeah. Thank you, Dr. Vivek. I haven't met you personally, but I get a feeling I know you since a very long time. Did we meet anywhere?
So we haven't met, but I think the first I did speak to you once. So I think it was through a message when this group, I think one of those ENT groups started, and you put in a message asking if I was so and so person. But then I have been seeing you through your videos and stuff. I mean, I have not met you in person. I have heard a lot about you, your students.
Thank you very much. Yeah. Dr. Vivek, we are waiting for other friends to join soon. Today, there are so many programs going on simultaneously. So they will join soon. Meanwhile, instead of me introducing you and reading out all the CV, I want to hear your journey from your mouth. How you started your medical career, how, your undergraduate education, then postgraduate education, where you got your super specialty training, your interests and things like that. Yeah, please, sir. Yeah.
Well, sir, I started I would say, in fact, I had my early schooling days probably outside India. Yeah, that was, I was born in India.
Wow.
I was brought up in Dubai.
Okay, interesting.
So till 10th I was there. And then after that I came down to Kerala. That is 11th, 12th I did my college here, and then from then on I have been here. So I joined my MBBS in the year 98. Yeah, that was in KMC Manipal.
Okay, very nice. Yeah.
So, and I completed that in 2004. And again in 2004 itself I joined for my post graduation.
Okay.
So that is in Sri Ramchandra Medical College.
SRMC. Okay. Yeah.
So it was Dr. Ravi Kumar who was my HOD at that time.
Yes.
Yeah, and Dr. Sanjeev Mohanty.
Yeah. He was one of our Maestro in one of our previous programs. Yeah.
So that was there, and in 2007 I did complete that.
Okay.
My post graduation. After that I came back. I joined Pushpagiri at that time. And I think that was the point. That was the time when Dr. Anthony Joseph was around. You would probably know.
Yes. I know him personally very well. He is my senior from PJ Chandigarh days.
Exactly.
I happened to work in Kerala long time back.
I
That
did
was
here, I
90.
think in North Kerala, right, sir?
Yeah. I was in initially. I was there a couple of months in Trishur, then in Chertalai, then
Okay.
4 years, long 4 years in Perintalmanna. I
Oh,
started the ENT department in Al Shifa Hospital. I was the
oh,
first person to be there. I set it up, one of the best departments.
yeah,
And when,
they're doing well. They are still doing well.
yeah, they're doing very well, actually.
Yeah.
Yeah, a lot of people after me,
Yeah.
Dr. Latif, my friend Latif was there. And he is settled in Australia now, very close friend of mine. After I left the department for him. And following him, his assistant was Dr. Sarfuddin, who is a big man in North Kerala now.
Yeah.
Yeah, and he was there. He was in the
So
department for
he is
quite.
again started his own
Yes, yes,
private setup.
yeah,
Yeah, yeah,
yeah. He himself is an entrepreneur.
yeah, yeah.
Very nice. Okay. So after post graduation, did you go anywhere for higher
Yes,
training
I
to
did
pursue?
come down immediately after post graduation. I did come back. I joined Pushpagiri, and
Okay.
that was the time when I had this opportunity to
Hmm.
work under Dr. Nishit.
Okay. Okay.
So I
Okay.
was with Nishit sir
Hmm.
for some time in Bombay
Okay.
Hospital. Did a fellowship under him in endoscopic work,
Okay.
and then subsequently again in 2008 I came back and I joined Pushpagiri,
Okay. How
and
long
then
you spent? How much time you spent in Mumbai?
Mumbai, I think close to 8 months.
Okay. Okay. Yeah. Long time.
Yeah,
Yes. Hmm.
yeah, and then after that I was here,
Hmm.
and then after that I know at different points in time I've been traveling, visiting centers, spending time. So
Hmm.
it has been on and off, like
Yes.
uh, for different trainings. I would say I did my endoscopic training in thyroidectomy from Vietnam,
Wow. Wow.
and
Amazing. Yes.
so
Yeah.
then after that I was there. I mean, I had attended the Grupo. Uh,
Otology. Oh.
yeah, pathology
Yes.
course.
Anxiety.
I was
Okay.
there for their courses.
Hmm.
So it has been something where yeah, been learning constantly. I would say all throughout from.
I think this is a golden word you have said. To begin with, learning constantly. I think learning never ends for a doctor, right?
Absolutely,
Yeah,
absolutely.
yeah, yeah, yeah. I think
So
that is one humility we have. That's one of the greatest character of a great surgeon, I
no,
would
I
consider.
think we have to constantly keep watching people,
Yes,
visit centers, see what
yes,
others do, and then
yes,
probably try to bring in whatever you think is possible into our practice.
yes. Very important point. Yeah, bring whatever good practices there, bring them to good point. I think you have given it two golden words to start with. I mean, that's fantastic. So now, not what is your focus of work at Tiruvalla? I mean,
Sir,
Pushpagiri Tiruvalla.
focus of work, yes, I would probably say I mean, I am a ENT surgeon to start with.
Yeah,
So I do all the work, but
yeah,
then
yeah.
my primary, I would say my focus or my areas of interest are predominantly endoscopic and advanced endoscopic work one. And
Very nice. Yeah.
otology,
Mhm, mhm,
again, otology and advanced and lateral skull base work.
mhm.
Yeah, so these are the two areas that I focus on the most. But then apart from that, yeah, I also do a little bit of retrosigmoid, minimally invasive retrosigmoid work and
Okay.
things like that.
Something like retrosigmoid minimal illness means
Yes,
microvascular decompression.
yeah, all
Say
those.
that?
Yeah. So we
Yeah.
do all
Okay.
those things. Yeah.
Okay. Okay. That's very interesting. I know. I saw that you are also a pioneer as far as cochlear implants concerned in Central Travancore area.
So we
Yeah.
started
That also.
yeah, in Central Travancore. Yes, we started off with the implant program way back in 2010.
Okay.
Yeah, but
That's
then
great.
we are still not uh, affiliated with the government scheme.
Mm-hmm.
So it is just private patients. Yeah.
Private case patients. Yeah. Yeah. Hmm. Yeah. That's good enough to start with. Somewhere we have to start because we have a very big
It has been
population.
going on, but then
Yeah.
yeah, so
Mm.
it's been literally catering to everything. So right now
Yeah.
we have a team
Hmm.
we have built up over a period of time. So there is someone who focuses on laryngology and
Okay.
voice and stuff. Yeah,
Very
so
nice. A
this
lot
is
of
what
focused work.
yeah.
Yeah, yeah. You have a neurosurgical teammate
Yes,
with
sir.
you for endoscopic skull base.
Someone who has been working. So I should say that I've been fortunate enough to be associated with
Hmm.
the head of neurosurgery in our institution, that is Dr. Dominic Canto.
Okay,
Yeah,
okay.
and apart from that, I have also been fortunate enough to work with few neurosurgeons in other centers.
Oh, very nice. Very
So
nice.
that way. So I mean that is how I think we grow. I mean, it's basically this kind of association that helps in the growth of the specialty eventually.
Yes, yes, you're right. Yeah, yeah, absolutely right. Absolutely right. Dr. Vivek, I mean, very nice of you to, to get a brief intro about, and also at the same time, get a very good insight about learning from you for the junior colleagues specifically. Okay, this is also being streamed on, live on YouTube. A lot of people will see, and YouTube also subsequently it will be posted on YouTube, and definitely this will be a motivational video for many many junior colleagues. With this, Dr. Vivek, I'm stopping sharing my screen. So please share your screen, sir. Yeah. Yeah, perfect. Yeah.
Is it on, sir?
Yeah, yeah, perfect, perfect. We can see. Yeah.
Okay. Uh, just a second, sir.
Yeah, yeah.
I think the screen is not coming on my. Just 1 second, sir.
Yeah, yeah. You think you should go to preferences and share to both of us or something like that. Yeah. Did your laptop got switched off? It's okay. Now it is there. I think Dr. Vivek, you'll have to unmute yourself. Please unmute yourself, Dr. Vivek.
Yeah. Hello, sir.
Yeah, yeah. Yes, yes. Okay. Now we have your voice. Yeah, you can start now. Yeah, perfect.
So thank you so much, sir, for this opportunity, for this invitation.
Yes.
A privilege to be here and to be a part of your wonderful series.
Thank you very much. Yeah, you're most welcome. Yeah.
So today we will just touch upon traumatic optic neuropathy. So I think one of the reasons why I specifically love talking about this is probably this is something that we have been working on for quite I would say a long period of time, probably 14 years. That is what my experience with this particular problem is. And the thing is that we have been working in a medical college. So this is something we come across, I would not say very often, but then yes, because we deal with or we come across so many patients with polytrauma. And many times this is something that I felt is that we miss out on.
Yeah.
And to be very frank, during my initial days of practice, I mean, many a times when the patient is brought to the casualty, I mean, this is not something that you actually look for or not something that you document initially, because all the focus would go into all other areas. You talk about fractures of the upper limb, lower limb, you talk about head injury, and you, vision is something that tends to get overlooked, in the sense it's not something that has been given its, I would say, due. I mean, you don't actually focus on it. And
I
what,
agree with you. Absolutely.
yeah, so the concern here is, and many a times we get called once the patient's general condition improves, which may take few weeks. Uh, you would probably say that many times severe head injury trauma patients would take weeks or months to recover. And at that particular point, when the patient kind of points out or says that he or she has a problem with vision, then you start going into it or looking into taking up that for further evaluation.
Yeah.
What happens most of the times is that at that particular point in time, there is nothing that could be done to the patient.
Yeah.
And retrospectively, when you look back, many of these patients during that stay in the hospital or during that time they're in the hospital, they would have gone to the operation theater on more than one occasion for multiple surgeries and whatever. And
True.
had we picked up this issue earlier, we could have probably at least attempted to salvage vision.
You're right. Absolutely right. Yes.
Yeah. So what happened is that when we started seeing these kind of references, then at that particular point we got in touch with the neurosurgeon. Then we told the neurosurgeon that probably this is also something that we should document or look at right from the beginning. I would say that from our experience and from us missing out on so many such situations, then we made it a standard protocol where we started documenting these findings right from the time of admission.
Yeah.
Because these are not patients who are going to walk into an ENT department or going to walk in to meet the ENT surgeon. These are patients who are generally admitted under the neurosurgery department. So it's
You're
usually,
right.
yeah. So unless and until you kind of convince the neurosurgeons that this is something that you can probably sort out if picked at the right time.
Yeah.
So I think that is the first and foremost important step when we talk about traumatic optic neuropathy. And I would say that from that particular point in time till date, over a period of time now, because of these long associations and what we have learned from our mistakes, we do look into this particular aspect.
Yeah.
We document any slightest suspicion of vision loss.
Yes.
We document it. And we also make it a point that most of these patients undergo imaging. So that
Yes.
instructions to our radiology colleagues to also focus on the optic canal and the optic nerve, because many a times it is just a CT brain that would be done. And you
You're
will.
right. Absolutely right point. Yeah.
So I think these are small changes that you need to bring about initially to kind of see these kind of cases, because many a times when I talk about optic neuropathy, people will be like, this is a controversial topic. I do admit that this is a very controversial topic, because many a times when you present this particular topic, you do have questions from people who have not dealt with optic neuropathy, who have not seen optic neuropathy, saying that does it actually work? Steroid is what is all that is required. I'm not here to make a statement that surgery is the treatment of choice, nor am I here to make a statement that conservative line of management works for all.
Right point.
So, with that brief intro, so what exactly happens in these patients? If you generally just a small, I would just give carry home messages. What you need to kind of understand why exactly this happens, and why do we need to look at this particular entity slightly different, in a different way than what we see with probably a facial nerve palsy, because I'm sure that most of the ENT surgeons would be seeing more of facial palsies rather than optic nerve injuries.
Yes.
And for some reason, there has always been a tendency to kind of compare.
Yeah.
Kind of, follow the protocols that you follow for a facial nerve injury in a patient with nerve injury.
Yeah.
But then this is an absolutely, I mean, it absolutely does not make sense, because these are two different types of nerves. They behave differently. And again, when it comes to treatment protocols, I would touch upon that later during the talk. So when you look at pathogenesis, we are basically talking about two possibilities. One is a primary shearing injury, in the sense you have the optic canal, and there is a fracture, and then what happens is that the bony spicules kind of press on the nerve, and eventually that leads to edema. There is ischemia. So it's something similar to a compartment syndrome. The nerve is getting compressed within that bony canal.
Yes.
So basically, when we are referring to traumatic optic neuropathy, most of the times we are referring to the intracanalicular portion. That is the part of the nerve that runs within the bony canal.
Yeah.
Because if you see the intraocular portion, or if you talk about the cisternal, the chiasmatic area, what happens is that it is fairly protected.
Yeah.
There is fat in the intraorbital compartment. In the intracranial space, it is basically not within a bony canal. So these fractures inducing this problem predominantly happens in the intracanalicular segment. And now I would say, as ENT surgeons, we are the ones who probably would the intracanalicular portion of the optic nerve much more frequently than anyone else.
You're right. Absolutely right. Yeah.
So secondly, you can have disturbance in cellular homeostasis. So there can be ischemia, reperfusion injury, secondary to release of certain free radicals. Now, this is the other mechanism of action. Now, you can also have a mechanism where the whole bony canal is intact, and the nerve there can be a hematoma. So again, the mechanism is similar to a compartment syndrome. So there is swelling, there can be a hematoma collection within this nerve sheath compressing on the nerve. Now, again, when you look at the classification of nerve injuries, as I had already mentioned, direct injury. So it can be a crush injury, it can be penetrating injury, there can be hemorrhage into the nerve, hematoma formation around the nerve, or it could be indirect, where there are transmission of forces to the optic nerve. Now, again, there are different classifications based on the site of injury. So I told you intracanalicular portion is basically the most common site, or the most commonest, the prone site for traumatic optic neuropathy. Again, based on fundus features, you have different classifications. Now, these are not very popular, and it does not actually make much of a difference when it comes to managing from the management point or the perspective. But something that is very important when you deal with traumatic optic neuropathy is the fundoscopy finding.
Yeah.
This is something that you should actually look into in detail. Now, many a times, if you go through the literature, now if you look at many of the articles that have come up in literature, they do talk about poor outcomes with optic nerve decompression, or they do talk about poor outcomes with medical management. Now, many a times when you look at these articles have been written, or these articles have been laid out just with taking into consideration your radiological finding and probably a pupillary reflex into consideration.
Yes.
Now, you would probably pick up an optic nerve injury with your relative FN pupillary defect, which we'll come to later. However, something that you'll miss out on is an optic nerve avulsion.
Yes.
Now, what you need to know is that if the optic nerve is avulsed, no matter what you do, you can't save the eye.
You're right. Absolutely right. Yeah.
So now how can you pick up this optic nerve avulsion? So practically on a CT, it's very difficult to make out if the nerve is transected or not.
Yeah.
So, however, if you do a fundoscopy, you can have ample evidence to say if there is a nerve avulsion or not. So if your ophthalmologist can actually rightly pick it up and tell you that the nerve is probably, this looks like a case where you suspect a nerve avulsion, there is no point going in and trying to decompress or trying to do anything to that patient. And eventually what happens is you take up such patients and then document saying that the procedure has given you poor outcomes.
Yeah.
So the key is selection of patients. The timing, when you see the patient, what patients you select, all these makes a lot of difference.
Yeah.
So just a brief overview of the anatomy. So since we are focusing on the optic nerve, now probably As you know, it has 4 segments. It is described under 4 segments. So first is the optic head, that is the segment just behind the eyeball. Then you have the intraocular segment, which is actually the longest segment. Then you have the intracanaliculaar segment, which is what we actually come across in your day-to-day practice. When you do open up the sphenoid, you see the bony bulge of the optic.
Yes.
You have the chiasmal part. So where it is intracranial. Okay. Traumatic optic neuropathy, as I told you, this is the area that we generally focus on. Now, these areas are pretty much protected. So it's not very common unless and you have some kind of a penetrating injury which injures the optic nerve at this particular segment. So this is the area where you have bony canal over it. So any kind of change there. So either it could be a compressive force or it could be edema within an intact canal. There could be a hematoma within the nerve sheath. At this point, what happens is that the nerve gets compressed and there is ischemia that can set in. Now, again, when we talk about the sockets, when you talk about the osseous anatomy, this is the optic canal. This optic canal occupies the superior and the medial aspect of the socket.
Yeah.
And this is actually separated from this fissure that lies laterally. This is a superior orbital fissure.
Yeah.
So this purple ledge of bone is a lesser wing of sphenoid, and this has 2 roots. So there is an anterior and a posterior root. And this posterior root is what we refer to as the optic strut. And this is what separates the optic canal from the superior orbital fissure.
Yes.
Okay. Now, this has relevance. There are structures which pass through the superior orbital fissure and there are structures which pass through the optic nerve canal. So when we talk about superior orbital fissure syndrome, we talk about cranial nerves that are involved here. So basically, we talk about usually the 3, the 4, 6. So these are the structures that pass through that. Whereas optic nerve is also involved, then it becomes a orbital apex syndrome.
Yeah, you're right.
That is, there are structures which pass through the optic canal. So optic canal, basically you have predominantly it is the optic nerve, you have the ophthalmic artery. These are the structures and certain branches from the 5th. There are certain branches from the 5th that run outside in the superior orbital fissure. There are certain branches that run through the optic. So I'm not going in detail into those areas. It may not be relevant from an optic nerve point.
Fair enough. Yeah.
So clinical features. So now what happens? Now clinical features, yes, sudden unilateral vision loss. Now, but it is very, very rarely that you will have a patient who is fully conscious.
Yeah.
Tell you that, you know, I noticed something abnormal with my vision. Because most of these patients will have severe head injuries. They would be comatose. They would have other associated. They can have extradural hemorrhage, subdural hemorrhage, bleeding, hand facial fractures, and all those. So most of these patients are generally intubated. Okay, so that is the so other associated major injuries, conscious level, ability and willingness to cooperate. All these are issues when you deal with these patients. So unless until you look for it, look for signs, you are not going to pick up.
True. Very important point. Yeah.
So visual acuity, again, you can have a subset of patients who can present with delayed visual loss, but this is very, very less likely, very less common. Now, the hallmark of picking up or diagnosing optic nerve injury is relative afferent pupillary defect.
Yes.
So this is a simple bedside test that you can actually. So with this, you can actually have a suspicion if the patient has a optic nerve injury or not. But this particular test also has its fallacies. Now, if the patient already has some kind of a pupillary asymmetry, there can be anisocoria, there can be patients who have pre-existing pupillary asymmetries. Now, you probably may not be aware of that. So you probably may find it difficult to interpret. But then these are relatively very uncommon situations.
Yeah.
The second important thing what we look at is color vision. Now, again, as I told you, you have limitations when it comes to testing color vision. Okay. Again, visual field defects. So color vision field effects, these cannot be done in patients who have altered consciousness levels.
Yeah.
Okay. So fundoscopy, however, as I had already mentioned, there can be a ring-shaped hemorrhagic area adjacent to the optic nerve head, which usually indicates partial or complete avulsion.
Okay.
So look for disc swelling, that is disc edema, that is pathogenesis. Look for atrophy.
Yeah.
Because atrophy usually will not set in immediately. It takes few weeks for the disc to get atrophy.
True.
So now if you are seeing a patient maybe 7 days down the lane or 10 days down the lane, and if you see disc atrophy, that means basically there is no point in doing any kind of intervention.
You're right.
Whereas if pale disc, if there are signs of edema, then try to correlate with your visual acuity findings, and then probably take a call on if something needs to be done or not. So, as I always say, surgery is not the first line of management. It is always complementary to steroids. So invariably, most of these patients would be started on steroids.
Yeah.
Because they'll have other associated multiple injuries. So most of these patients would be put on steroids.
Yeah.
So what exactly is the role of surgery? So if you look at it as we were talking about the concept, that is, we are talking about compartment syndrome. So if it's a compartment syndrome, basically you are looking at options to relieve that strangulation of the nerve, the compressed nerve, you would like to relieve it and re-establish the nerve function. In other words, try to restore the blood supply. Now, whatever narrowing or whatever compression has happened, try to restore that. So that is what you are aiming at.
You're right.
So now the question is, what are the patients or the subset of patients whom you would take up for a surgical intervention? And secondly, what exactly do you mean by a decompression? So when you say decompression, when you're talking about endoscopic optic nerve decompression, you're basically referring to removal of at least 50% of the circumference of the osseous canal. So this osseous canal is approximately 10 millimeter in length, or I would say 1 centimeter. And you have to remove at least 50% of the circumference. So from an endoscopic perspective, what you would be, or what you would be able to remove is just the medial aspect of the optic canal.
Yeah.
Yes.
But 180 degree.
Yes. Exactly.
Okay.
Second, you have to remove the bone along the entire length of the canal. So this canal begins right from the orbital apex till the nerve exits, goes in intracranially.
Okay.
So that is the whole length.
Yeah.
Now, a controversial point would be incision of the dural sheath. Now, this is something which still is a controversy. Do you want to do a nerve sheath, optic nerve fenestration in all the cases? Well, we don't. We did that initially, but then we have changed over a period of time, and we have selected indications for doing that.
Okay.
And the primary indication would only be a nerve sheath hematoma.
Okay.
If you see a nerve sheath hematoma, obviously just by uncovering the bone and decompressing the nerve, things may not work out. You'll have to make a incision and open up the sheath and evacuate that hematoma. Now that probably would be the most sensible indication for a sheath fenestration or optic nerve fenestration.
Yeah, so, important point. Yeah.
Now, indications. So when do you take up? Now, radiologically, if you have evidence of bony fracture impinging on the optic nerve, obviously, if you get a high resolution CT scan, focus on the optic canal, that will easily tell you if there is any kind of display. First of all, fracture. Secondly, if there is displacement. Third, if there is impingement. Optic nerve sheath hematoma. Now, this is something that you cannot pick up with the help of a CT.
Yeah, you're right. Yeah.
You have to do an MRI to pick it. If you see a intact optic canal,
Yeah.
with features of optic neuropathy. Then suspect a possibility of a hematoma.
Yeah.
So include an MRI. So again, now documentation of vision. So now this probably would only be possible in patients who are conscious.
Yeah.
So vision less than 6/60.
Yeah.
And as I had already mentioned, you get a call. Now most of these patients would be on steroid. Now, if the patient is awake, you can actually document. Now you can assess if the vision is improving. So you have different ways. Now visual acuity is one way. Then you look at finger counting. You look at perception of light. So you document no perception of light. So these are the things that you need to document.
Okay.
Now, if you have a documented visual acuity, now if you see on the second day after starting steroids, if you see it is worsening,
Mm-hmm.
that is a red flag sign
Okay.
with steroids.
Mm-hmm.
Now, if there is improvement, you are fairly happy, you have time.
Mm-hmm.
So, if there is failure to improve, if it is static or if it is deteriorating
Mm-hmm.
after mega dose steroid therapy, these are the situations where you have to consider
Mm-hmm.
a surgical intervention.
Yeah.
So, time is the single most important factor.
You're right. Absolutely right. Yeah.
With optic nerve. Now, here is where I always keep emphasizing on the difference between a facial nerve and an optic nerve.
Yeah.
Now, why do we emphasize so much on this? Now, optic nerve is a sensory nerve.
Mm-hmm.
Okay.
Yeah.
Now, facial is a mixed nerve.
Yes.
Now, almost all the peripheral cranial nerves have neurolemma.
Mm-hmm.
Now, whereas optic nerve does not have a neurolemma.
Yeah.
Okay. Now, just imagine a situation of facial nerve. I'm sure, sir, you would have probably gone through that. You would have probably worked in the era where people used to jump on any facial nerve, post-traumatic facial palsy to decompress.
Absolutely right. You pointed out rightly. Yes.
Because I mean, during my training days, we did have, because we now what has happened is over a period of time when you look back now,
Yeah.
when I probably you have a longer time period to look back, so you would
Yes.
probably know how it has evolved. Now it is
Yes.
almost
Yes.
watch strategy.
Yeah.
And the thing is that you have something, you have other options. Now the thing is, you do it after 3 months, it still works. You do it maybe 4 months, 5 months also, it works.
Yes.
When it doesn't recover, you have other alternative options.
Yes.
You have dynamic procedures, you have static procedures,
Yes.
you can graft.
Mm-hmm.
Okay, so
Yeah.
all these there's a whole variety of options.
Mm-hmm.
Unfortunately, with optic nerve, that is not the situation.
Absolutely right.
Now, what is lost is lost.
Yes. That's forever.
Yeah, to me, when people talk about, when people debate,
Mm-hmm.
say, we have protocols have changed in facial nerve and this. See, the issue here is, to me, when we say optic nerve injury, it is something like resuscitating a patient.
True.
It is like a CPR.
Yes. More than that.
You give an attempt, you try it. That is the last opportunity that you have.
Yeah.
Nothing else is working. That is the last opportunity that you have.
Mm-hmm.
You give it a try. In a well-selected case, provided everything is favorable. So we'll come to what are the unfavorable situations when we go through a series. So then it can work.
Yeah.
So there is no point in waiting for miracles to happen once you know that steroids are not working beyond 48 hours. Now there is no point trying to do anything usually beyond a period of 7 days in optic nerve. By that time already the damage has been done.
Yeah.
And the other problem here is, now it is usually just with imaging that we'll have to go in most of the times, and simply with a relative pupillary defect, once we confirm that, you may have to go in, because
Yeah.
patient already has an altered sensorium, or patient is not conscious.
True.
Patient may be being taken up for maybe a decompressive craniotomy or evacuation of a hematoma or whatever.
Yeah.
Now, if suspect in the same sitting, you could even probably, if you have a clinical evidence, along with radiological documentation of an impingement, you could just decompress.
Yeah.
There is no harm. Rather than waiting for the patient to come back to his conscious levels, maybe 7 days or 10 days later, and say that I can't see anything in his eye.
True.
And again, when you look at other testing options, other investigative options, apart from radiology, I think most of the now visual evoked potentials and ERG are things that are mentioned, but unfortunately, these can't be done bedside.
Yeah.
So that is the area again where we have a difficulty. So we'll have to stick on to our clinical skills, or the clinical judgment.
Yeah.
So we cannot rely too much on investigations here apart from radiology.
And these are not commonly available also.
Very true.
This VEP and
very
ERG, electroretinogram, visual evoked pathway, not available.
Absolutely.
Yeah.
So accessibility is a problem.
Yeah.
So with that, so I think that is just a brief introduction. I just mentioned about what the mechanisms are, what are the possible ways that problems can happen. Just a brief overview of the
No, that was very, very important actually to understand the basic concepts. That makes one very clear about this entity. Yeah, go ahead.
And so the whole emphasis on your bedside examination.
Yes. Okay.
So I'll just show you few clippings, sir, and
please
take it along.
Yeah.
So let's see few scenarios.
Okay.
Now the first scenario is this particular scan. So if you see here, now you can see the sphenoid sinus. I haven't put the entire series here.
Yeah.
You can see the sphenoid.
Yeah.
Now you can see an onodi situation here.
Yes.
On the right.
Now
there is some kind of opacification here.
Yeah.
See, there is a fracture here. There's a fracture here. So in the vicinity of the carotid, in the vicinity of the optic nerve, there is a tilted bony spicule.
Yeah.
Okay.
Yeah.
A very classical scenario. Now, what are the limitations of radiology? Now we will probably see as we go through this video. Now, if you see, this is the view. So that was the endoscopic view of the right nasal cavity. So there is a large concha bullosa, which we have already completed a lateral lamellectomy. So now we have the uncinate, you have and the middle turbinate in picture.
Yeah.
Right. So now in this video, I will probably take you through it step by step. So again, you'll have to perform or follow the steps of your conventional endoscopic sinus surgery. That is start with uncinectomy. Now the choice is yours. Use a backbiter, use a debrider. Now what I'm showing is basically using an elevator. Okay. So just make an incision, and, reflect the uncinate.
Yeah.
And that opens up into the maxillary sinus. In most of these cases, if you see you can see that there is altered blood.
Yeah.
So these are all post-traumatic cases.
Yes.
Okay. Now, once the maxillary sinus is identified, the next step would be to open up the bulla.
Yeah.
Now, remember one thing. Post-traumatic cases.
Yeah.
When there is associated panfacial fractures, the whole ethmoid sinus usually will be shattered. There will be a lot of bony spicules. Sometimes the lamina will be shattered.
Yes.
Don't be under the impression that it is like doing a routine endoscopic surgery.
Absolutely right. Very important part.
That is a challenge here. Now, no matter how much time you spend with the CT scan, now it is a totally shattered anatomy that you're going to see.
True.
You would probably focus on your important aspects. Now, you would probably have a look at the skull base. You would have a look at the optic nerve. You would have a look at the carotid, the lamina.
Yeah.
Now, you look at these structures. Is there anything unusual there? Now, you can't study all cell by cell anatomy in these kind of cases.
Yeah.
So again, resort to either your cold steel instrumentation or a debrider. Open up the ethmoid. So in this case, if you see now, once you go inside, you'll see all bone pieces. Can you see that?
Yes.
Similarly, you see this yellowish discoloration, which is very common finding that you see, because this is because of that hemosiderin.
True.
blood coming in contact with the mucosa, over a period of time, it will give that yellowish kind of an appearance. So if you see here, now you can see bony spicules lying here below, so all over the place. So important thing is you stick to your normal structures, whatever you can actually kind of visualize. So laterally, now most of the cases, the lamina papricium may be intact. Now sometimes the lamina, we'll show you situations where the lamina papricium is totally gone and how you go about it.
Yeah.
What you do is you try to get into your safe zone first. Now you can't go and identify your skull base because most of the times the skull base will be fractured. There will be fractures along the skull base. So unlike how you do in endoscopic sinus surgery, you can't just go and delineate the entire skull base very easily. The whole thing rocking or the whole thing may be floating around. So instead of that safe zone, so as I had shown you earlier, I opened up the maxillary sinus, and now if you see, my instrument is placed in the inferior part. So I would probably try to get directly into the sphenoid sinus first. Okay.
Yeah.
Here. Now you can see that. So once the ethmoid cavity is opened, stay your middle turbinate, superior turbinate, and get down and open. So you saw that this is an onodi situation.
Yeah, right.
Is the screen shaky, sir?
No, it's perfect.
Is there some disturbance on the screen or only?
Not at all. Not at all. Not at all. It's
So
perfect for us.
So now if you see, I have opened up into the sphenoid. The normal areas you identify.
Yeah.
Now, here in this particular case, the lamina did not show much of an involvement. So we have kind of stripped out the mucosa. So this is not a functional procedure. You have to close the lamina. So you'll have to strip out the mucosa. You'll have to use drills, all these things. So you have to get adequate exposure.
You're right.
So now if you see, now this is the whole lamina.
Yeah.
Right at this, if you follow this lamina, this is something like a pyramid.
Yeah.
So if you see where my arrow takes you now, this is the superior part, and as you go posteriorly, it cones down.
Yes.
Similarly, from here, inferiorly, it cones down. So where it cones, the apex of that pyramid is actually the area which corresponds to your orbital apex.
Yeah.
And many a times in that region of the orbital apex, the bone is kind of very thick.
Yeah, you're right.
So I will have to actually polish that. So that is what I'm doing here. Because either you'll have to use a punch.
Yeah.
So if you see, you're flattening that area out because eventually you'll be removing this.
Yes.
I'll tell you that when we come to that point.
Yeah.
So this is the view which shows the apex. This is actually part of that posterior ethmoids.
Yeah.
Anteriorly is the sphenoid, which we already opened.
Yes.
This is that cell that we have.
Yeah.
So this is a scenario where you can have confusions. Now, where exactly is the optic nerve? Now, again, if you go back into the relationship of the optic nerve with the sphenoid sinus, you have classifications which talk about, apart from onodi, classical onodi, there are different types.
Yeah, right.
Within the sphenoid sinus, it can be within the onodi cell, it can be outside the onodi cell also.
True.
So now we just open up that cell. So again, the safe zone. So inferiorly, I address the safe zone. I know the optic nerve comes somewhere in this area. Now everything looks kind of distorted. So I know that this is not the area where the optic nerve is. So work in your comfort zone. Identify all the possible landmarks that are not distorted.
Yeah.
Don't get into an area of distortion and then eventually land up with confusion.
True.
So if you see how we have worked up all these areas, so we have identified the lamina, we have identified the sphenoid. So it's basically a 360-degree kind of exposure around the area of around the site that we are going to work in. Now you could probably ask me a question: why am I spending so much time directly go with the optic? Now you saw
No, this is very important point you're making. I'm keenly listening. I'm sure all our participants also listening keenly to you. Yeah.
Now why am I taking too much of emphasis on this exposure? Now remember, always expect the unexpected in a case of optic neuropathy.
Yes.
Now you have fractures. So I told you the skull base can be fractured. So I told you that is the reason why I'm not going aggressively trying to expose the entire skull base. Now probably when you took up this patient to the theater, this patient would not have had a CSF leak.
True.
Now on table, you would probably be trying to delineate the skull base like how you do for an endoscopic sinus surgery, and you remove one of the fractured segments and there you'll have a gush.
Yes, you're right. I have faced it myself once. Yeah.
Two, I showed you the scans and I told you that you have a tilted spicule.
Yeah.
Just below is the carotid.
Yeah. That's very important. Yeah.
There can be impingement on the carotid.
True.
Now, unless and until you are kind of prepared with your exposure. Now, let's see the worst come worst scenario. Just 1 sec, sir.
Yeah, go ahead. We have all the time in the world. Yeah. Yeah, I'm sorry for the interruption, friends. Looks like speaker has some connectivity issues. He will be back soon. Yeah. Yeah, you have to play the PowerPoint. Yeah, please. Okay. Again, is losing the internet repeatedly. Mm.
Hello.
Yeah, you're back. You lost your internet or something?
No, I don't know what happened, sir. There was something because in between it is saying that the host has muted you, so I was not able to.
No, I'm not muted. Yeah.
I was not able to open it up. Now, are you able to see my screen
Yeah,
now?
yeah, yeah. We are able to see. Yeah.
Sorry for the technical.
And you're okay. I'll make you co-host again. Let me see. Okay, your co-host again, and let's see. Perfect. Yeah.
Okay, sorry for the technical
Yeah,
issue.
I know. We keep having this problems.
Yeah, so we were basically focusing on why
Yeah.
am I spending so much time going all around? So
Yeah.
sometimes you can have a spicule on the carotid. Now,
Yes, that's the point we were
be
discussing.
careful. Now, what
Mm.
happens is accidentally you pull it out, and if it bleeds,
Yeah.
if you don't have enough space to control that bleeding, then it becomes a real mess.
Yes.
So might
Got it.
as well be well prepared. So if
Hmm.
you have kind of drill out all the bony areas, in case you have a carotid bleed, you can at least pack it properly.
Yeah.
So exposure is the key.
Yes.
Okay. So
Yes.
now
Yes.
if you
Very
see,
important point.
so we
Yeah.
have opened up that cell, the sphenoid is down here. Now this is
Hmm.
the area where the fracture is. So you can see this bone pieces
Yeah.
here.
Yeah.
Now the next thing, as I told you,
Hmm.
is following the lamina towards the optic.
Yeah.
So it's like a pyramid, it's like a
Hmm.
cone.
Hmm.
What you need to do is just elevate the lamina. Now you need not elevate the lamina all the way anteriorly.
Yeah.
Somewhere midpoint is enough. So if you see, I've retained the lamina anteriorly.
Hmm.
So somewhere at the midpoint,
Mm.
just elevate it.
Yeah.
This should again be done carefully. Why?
Yes.
Because if you breach the periorbita, fat will
Hmm.
collapse.
Yeah.
And once with fat in the field, it becomes kind of difficult. And you can actually try putting some surgicel or something on the surface and try to push it back, or you can gently cauterize that fat. But then try
Yes.
as much as possible to avoid. No, that is the remedy that I was talking about in case you land up with a situation like that.
Yes.
So you should know what to do, what not to do, and what to do when you land up with a problem as well.
Yes.
Okay. So once that piece of lamina is taken out, you can actually see the optic nerve coming into view.
Yes.
Okay, the beginning of the optic nerve.
Yes.
Now we all talk about, so if you see now, this is a periorbita, and at this point, there will actually be a fibrous band. Now I'll show that in the subsequent videos. In some cases, it's very clear. So
Hmm.
this is what we refer to as an annulus of zinc.
Yes.
Okay.
Yeah.
So now that is the band that covers or
Hmm.
kind of encircles the area of the optic nerve. Now that is basically the site from where you have the common origin of the extraocular muscles.
Yes.
Okay.
Mm.
So now once you take out the lamina, you start seeing the optic nerve coming into view. So this is the initial part of the optic nerve. Now if
Yeah.
you see here, now all this is fractured bony spicules.
Yes. Yes.
Okay. Now if you see carefully, this is all fractured segments. But
Yeah.
then you see, I'm just gently teasing out a small spicule here.
Yeah.
Can you see that?
Yes.
Now, if you see, that is actually piercing the optic nerve.
Wow.
Okay,
Yes.
fine. So now if you see, this is part of the optic nerve. There is
Hmm.
still this bony impingement superiorly.
Yeah.
So by definition, we were talking about more than 180 or more than 50% of the circumference has to be cleared up.
Yes.
Now we continue with elevating the more fractured segments. Now all this you'll have to do gently with a gentle movement. In the sense, don't use forceps to pull it.
Yes.
It be gently reflected away from the underlying structure, and then you take it out.
You're
now,
right.
If you see here, there is this fractured segment superiorly. Now, this is something which I tried moving, but I knew the minute I tried taking it out, the whole thing will just fall off.
Yeah.
So what I decided was to just use a polishing burr, low speed. Now, if you see here, just keep your pressure onto that bony segment and just polish it out. So you will have a space above the optic nerve, that is a supraoptic recess.
Yeah.
Now this you see only in well pneumatized sphenoid sinuses. Now if you see that, now can you see that area that I drilled out here?
Yeah.
So now if you see that superior part is free, now this is where we had impingement.
Yes.
And now if you see, now there is still a bony fragment here. Now this is the area where you come across your carotid.
Yes.
So if you see, once I remove that, now you can see what we refer to as your opticocarotid recess, the lateral carotid recess. And this is the clinoid segment of the carotid.
Yes.
Now this again takes me back to the point that I made. Now, had I not opened up all these areas, in case it bleeds, I won't even be able to hold the suction in place.
True.
Okay. So before you work around the carotid, or if you have a suspicious carotid involvement, always expose the entire area, be mentally prepared so that in case something happens, you have space to pack, you have space to control it. So this is actually the view here. So you see all the way from the orbital apex. So you can see this band, vertical band running here. That is the annulus. I'll show that better in some other video. And you take it all the way till it goes intracranial. So I was talking about the predictive factors. So now when you have a bone which is impinged or pierced,
yes,
the prognosis is not great.
Yeah.
So this is what you will not be able to predict with your CT scan. If that nerve covering has been pierced, if the nerve fibers have been impinged on. Now, if it is just an external compression without, piercing, fairly the results are good. Now, this is not something that we can predict early. Now, this is something that generally we come across, encounter at the time of surgery. So that now this particular patient, why I showed you is that now these are the kind of scenarios where you don't get satisfactory outcomes.
Yeah.
Because you really cannot estimate or cannot kind of quantify what percentage of the nerve fibers have been damaged.
Yes.
Now let's see another situation. Now here, now I showed you how you start with the initial part. So the initial part is more or less the same, doing an uncinectomy, ethmoidectomy, and then delineating the whole space. Now in this patient, now this is another scenario. This is a left nasal cavity. So if you see, we have opened up the ethmoids. Now the entire lamina is fractured. So if you see, you can already see the periorbita here. Can you see that?
Yeah.
Everything is fractured. Okay. Now I'm going down into the sphenoid area. Now there is a lot of distortion.
Yeah.
So when you have distortion, you try to kind of, spend time to kind of identify what exactly is happening around. It is again not like a routine surgery. So if you see here, I can make out that roughly this is the area where you have the posterior ethmoidal artery. But you see the posterior ethmoidal artery here?
Yeah. Very clear.
So that means that roughly tells me that this is where the anterior face of sphenoid would be.
Yes.
But then I'm seeing all these bone pieces sitting inside and mucosa inside. So what literally has happened here is that the entire anterior face of the sphenoid is fractured and has gone into the
Sphenoid sinus.
Sphenoid sinus. Are you able to see the video?
Yeah. It's perfect. Very nice. Very clear.
Okay. So just again, I think I have one second.
Yeah, it's not opening. The presentation is, you can unmute Dr. Vivek. Yeah.
Are you able to see the screen, sir?
Yeah, we are able to see the screen, but we are seeing your desktop where you are opened the find, you know.
Okay. What
Yeah, my
exactly are you
passport.
seeing? I think.
You have opened my passport, contents of the my passport.
Okay, fine. I'll just show that.
Yeah. You have to open the presentation and share it.
Yeah, I think there
Share the
is
present.
some technical issue. I don't know what exactly is happening because I'm not too techie also, so that is a problem. Now?
No, not yet. Not yet.
Now?
Mhm.
Now?
No. So what you have to do is, it is open for you, the presentation,
Yeah.
and you go to share screen and share the presentation again.
It's written,
The,
yeah, resume share. Okay.
yeah, presentation, that PowerPoint.
I'll open that now. Yeah.
Yeah. Now first you have to open the PowerPoint presentation,
Okay.
or you're using this thing, na? What
Yeah.
Keynote. Open the
Yeah.
Keynote first, and go to share screen and share the Keynote.
Okay, it's open now.
Yeah. Now go to share screen.
Resume share.
Yeah, resume share. Yeah.
I'm having some technical issue with the laptop, I think.
Oh, okay.
Now is it okay?
Yeah, no, it was coming so nicely. Suddenly what
Now the
happened?
video?
No, nothing is seen now. I mean,
Okay. Now,
only that still we have this thing.
okay, what I'll do is I'll just once again share it. One sec.
Yeah.
Are you able to see the screen, sir?
Yeah, we see the screen.
Yeah,
You
now
see
the
your desktop, that this thing, you open the my passport to this thing.
now
Now you have to share the presentation.
video running along. Wait one sec.
It is running for you.
Yeah, just that is what.
Mhm.
Just close it up again.
Yeah, double click that presentation.
Okay.
It is open for you.
No, now it's
Probably because the presentation is too big. It is
now.
3.5 GB. No. You will have to go and reshare it on the share screen. Share
Okay.
the presentation, that key for that
New
keynote.
share. Okay.
Yeah. Go to share screen.
Yeah. Now
Yeah. That's it.
I'm very
Go to
sorry.
play. Now the play the keynote. Yeah. It will come now. Yeah. But this is very large file. Probably that's why it's going. It's almost 3.5 GB.
No, the issue is I am slightly technically.
No, it's okay. We all we are we are learning every day.
No, but the problem is when I put it on that full screen, it doesn't come on my screen. So that is the issue. That is what I'm
Yeah,
facing.
okay, don't put it on the full screen. Don't play that. You can play it like this only.
I will minimize it and play it then.
Yeah, play like this. It's seen now.
Okay.
Yeah, you can play the video here only.
Yeah, so I have an issue again. 1 second, sir.
Yeah. Yeah, you can play here only.
Can you see the screen, sir?
Yeah, we can see the screen. You can play here only. Yeah.
Do it from here itself.
Yeah. Do it here itself.
Yeah, I think that is the best option.
Yeah. Go ahead. No problem.
So basically what you see here is, as I mentioned, this is the left side. So the periorbita is already exposed.
Yes.
Lamina is fractured. So now the thing is, I am not finding the anatomy in its normal location.
Yeah.
So the landmark that I could probably pick up, and now secondly, when I just strip this mucosa, I'm seeing clear egress of fluid. Now this patient did not have
Yes.
This is what I was talking about, the situation. Now, the only landmark that I'm familiar at this particular point is the posterior artery. So that tells me that I'm right in plane with the anterior face of the sphenoid. What exactly has happened in this case is that the entire anterior face of the sphenoid has got pushed inside. So
yeah, you're right.
Fractured it. So now this is a difficult scenario in the sense you don't know what is behind. Now the carotid, everything is there behind. You don't know how deep this bony spicules have gone in. Now your scans cannot actually tell you all that.
Yeah.
It's distortion. So when you have a situation like this, you have to gently dissect and then take out this bony spicule. So if you see here, I'm using an elevator and freeing it from its surroundings and then using a forceps to take it out slowly.
Yeah.
Now, why this is important is now, as I had already mentioned, this could be sitting on the carotid. This could be the dura.
Yeah.
Now, again, I'm gently using instruments to take out all that mucosa. I'm going towards the floor now.
Yes.
I still don't know where the carotid is. I still don't know where the optic is. So again, the next bony spicule is being lifted off.
Yes.
Now, if you see, there are two pulsations. There is a pulsation here and there is a bulge here. Now, this is slightly grayish. The pulsation superior is white.
Yes.
Now, that white color tells me that that probably is the dura with the pulsations. But then what is this bulge below? Now, that is unlikely to be the dura. In the floor, you will not see a dural bulge.
Yeah, right.
So what we did is just made an opening in that. And you can see there are a lot of clots that came out. That is ballooned out mucosa of the sinus because of the hemosinus.
Yeah, right.
Now, so posterior ethmoid artery, I saw the pulsations of the dura. Now I start working from a safe zone below. I'm still not going laterally. You have your optics and the carotids coming up laterally. So debride and opened up that mucosal space. Now that gives me more view.
Yeah,
so dura pulsating here. And again, another bony spicule. So still I have not seen my optic. There are so many pieces that have gone into the sphenoid sinus. You see that large piece is again gently lifted off.
Yeah.
Now, in these situations, a CSF leak is actually a blessing in disguise because it actually keeps flushing your field.
True.
Okay. So you see the pulsations, and now I start seeing the optic here. And again, still see more pieces coming out.
Yeah.
So you can just imagine now how many pieces we have removed before we start seeing the optic. Now you see this big piece.
True.
So again, the same way, gently dissect, take it out. Now, we would trace the orbital apex anteriorly, like how we did in the previous case. Now here, partly the lamina is already missing. Take out whatever is fractured.
Yeah.
And then start moving in.
Yeah.
Okay. And again, you will have to identify your orbital apex. So if you see, now you see this is apex. From this yellowish periorbita to the white optic nerve.
Yeah. Yes.
Now you see the dura and you see how the optic nerve is piercing the dura and goes intracranially.
Yes, beautiful.
So that is the 360 degree. So now the challenge here is to close off the CSF.
Yeah.
So you have to plug fat. So it is something like your dumbbell.
Yeah.
Push it in.
Yeah.
And then finally on that, you can actually place a layer of your fascia.
Right.
Now, another important thing is you cannot pack it like how you do a conventional packing, in the sense you have just laid the optic nerve bare. So you cannot actually apply too much of pressure on that optic nerve.
True.
But situation like this, now here what we have done is we have put a pack with a gloved finger.
Yes.
That is basically your rubber gloves into
yeah.
So that it does not sit directly on the optic nerve.
Okay.
Now, that is just used as a support for your graft. I mean, for your repair. So when it comes to, when a CSF closure comes too much important to the what do you say, optic nerve, exposed optic nerve, be careful not to overpack it.
Okay.
Yep. So I think that is another scenario. So here, so I think I've just shown 2 cases. Now I can show more cases. I don't know what the time says because I have some technical issues with my laptop also. So it's giving me some trouble.
Okay.
A couple more cases, or we can probably discuss, because again, I think for some reason I'm able to talk right now, but then the screen has gone off. So I'm not touched anything right now, because again, if I do that, then it goes off again.
Yeah.
Otherwise, we had 2 more situations which I could have shown, but then otherwise I will log in. But then we can continue with the discussion. I will just try.
Yeah. We'll continue the discussion.
Yeah. Okay. So these are the important points that I actually wanted to convey. Now, if you see, when you talk about traumatic optic neuropathy, as I always mention, don't look at it as a single entity. Be prepared to deal with a CSF leak. Be prepared to deal with a possible carotid injury. So like what I showed in the first case, you can have a carotid that is exposed. When you remove the spicule, sometimes it may bleed. Or as in the second case, you can have a CSF leak. Now, it may not be something that you would have anticipated, but you should be mentally prepared to deal with these scenarios.
Yes.
So that is one of the primary carry-home messages. 2, don't expect it to be a cakewalk. This is not normal anatomy. This is distorted anatomy.
Okay.
So be ready, in the sense you would not go with your conventional techniques, like saying, you open up the bulla, you see the ground lamella, you open up the ground lamella and then go in and identify all this.
Yeah.
Because the ethmoid will be shattered in most of these cases. There will be color, there will be discoloration. I showed you how it looks yellow because of hemosiderin. You will find clots in the cavity.
Yeah.
The whole thing may be rocking. So you would be in a dilemma if you have to actually remove that bony spicule or not.
Yes.
So there are so many things that actually go through your mind. So it's an altogether a different ball game.
You're right.
The exposure is the key. Exposure primarily, now you could probably say that you can just pull it out and decompress and come. But the exposure is primarily keeping in mind the possible complications that you're going to land up with.
Yes.
The next important point is how you deal with the optic nerve. So
Yeah.
eventually you are going in to make an attempt to salvage that eye or salvage the vision.
Yes.
You can't just push around the optic nerve.
Mhm.
So sometimes probably that entire sheath may be intact.
Mhm.
Now, because of your manipulation,
Yeah.
the, the edge of this spicule may pierce it,
True.
and you probably end up damaging it even more.
Mhm.
So as I mentioned, now if you find a very thick bone, use drills to thin it out. Now, if you find resistance, don't force yourself.
Yes.
Thin it, flake it.
Mhm.
Judicious use of instruments.
Yes.
So you have to use the appropriate instrument at the appropriate in the appropriate region. So generally, if you see, we use all these even micro ear instruments, I would say, like your, flag
Yeah.
knife,
Yeah.
round knife. These become very handy when you work around the optic nerve.
Yeah. You're right.
So instrumentation, what to do, what options you have, your
Yeah.
thought process, anticipation of complications,
Yes.
everything has to be in place when you deal with optic neuropathies.
You're right.
So now I can't actually change my slide. So I'm just continuing with what is there on the subsequent slide. So if you look at the largest pilot study, now unfortunately, if you see, it is very difficult to do a randomized control study with this particular topic.
Yeah. Yeah.
But then the largest study that you have, a pilot study, is the International Optic Nerve Study, where
Mhm.
they have kind of pooled in data from around 72 centers across the
Yes.
world.
Yes.
Now, what they say is that no single method is the treatment of choice.
Yeah.
In the sense, neither is medical management the treatment of choice, nor is surgical decompression the standard of care.
Yeah.
So it has to be used judiciously. So based on a patient to patient basis, you will have to select what is appropriate for the patient.
Yeah.
So we had already specified what exactly are the indications where you have to think of a decompression.
True.
So I now, if I were to go through my experience, I would say probably over a period of 14 years, we have a series of around 32 cases now.
Yeah. Very good. Very good number.
Yeah.
Fantastic.
So now we have actually sent it for publication. So it is not yet published. But then again, I would say the results. Now, I
Yeah.
would say if I am, the way I look at it is, if I am able to even salvage one eye,
Mhm.
I'm happy about it.
You're right.
So if you see in our series, I would say like it is almost a 50-50 situation.
Mhm.
In 50% of the patients, we have been able to improve the vision drastically. Now, unfortunately, I can't put up that statistics slide. It's there.
Okay.
And if you see, there is a subset of patients who would have improvement in vision by at least 3 lines. So that is what we consider generally as uh, improvement. In the sense, now when you say someone with perception of light has finger counting at distance of 1 meter, it does not add too much to.
Yeah.
It is not significant improvement.
Yeah.
Whereas if you're looking in the Snellen's chart,
Mhm.
now if you can improve it by 3 lines on that
Yeah.
Snellen's chart,
Mhm.
that is something that we call a statistically significant or useful vision.
Okay. Hmm.
You can't say that the patient from no perception of light after decompression, no patient has perception of light. That is absolutely of no use.
True.
So unfortunately, we don't have any kind of a system which kind of assesses what is pre-op improvement, what pre-op versus post-op improvement. Every paper, if you see, they say that there is improvement.
Yeah.
Now, what is this improvement? You have to quantify.
True.
So that is what we have actually kind of proposed when we say that at least by 3 lines only, that is what we would consider as useful vision.
True.
So now these are the things that we need to actually think of. In the sense, now if you ideally when you look at the flaws in most of these studies, there is absolutely no standardization when time is taken into consideration. There is
You're
no
right.
standardization on what patients you have taken, what was the visual status, what was the radiological finding,
Mhm.
when was this patient taken up for decompression. You don't find these kind of standardization. It's like comparison of a patient who's taken up for decompression at 10 days versus a patient who is taken up for decompression on first day, second day. So there is a lot of bias there.
Yeah, you're right.
Specify the time period. You say these are the indications, you have tried these. No, you really cannot. So that is a technical challenge with doing studies in this subset of patients.
You're right.
So for us, it has been a retrospective analysis. We have been going through our data, seeing what we have kind of put up. But then again, what we have learned over a period of time is now, in general, if you find if there is feature of avulsion, there is no point doing it. In fact, one of the last cases that we did was a case of a bilateral optic nerve injury.
Yeah.
And the sad thing is that this is a very young boy. He was 16 years, both eyes. And I would say we were fortunate enough to salvage the vision in one eye. And the other eye, obviously, it was an avulsion. Although because we were going in, we just made an attempt to explore and see, but then eventually at least one eye could be salvaged.
Okay.
So whatever said and done, there can be debates. Now, there are people who argue that, it is the effect of steroids, because you do continue steroids even in the post-operative period. But then the question is, why did this change happen after I took up the patient for decompression? Why not before? Why didn't the steroid act before?
Yeah.
So I would say it's always something that goes hand in hand. So they complement each other. So you have to depend on steroids, but then again, you can't always say that steroids will do the job.
True.
So I think that is something what I wanted to. I'm very sorry for this technical thing. I really can't figure out.
Okay. Understand. Yeah. Anyway, you put your point across. That's important. Yeah. Your thoughts across,
Think
we have a lot of take-home message in this, whatever you spoke till now. That is what is more important. We have these problems now and then. It doesn't matter. Yeah.
In fact, I had a couple of videos more which could have shown where I was showing actually the fenestration. So I think I'll just put a word on fenestration also, sir.
Yes, please. Yeah.
So fenestration, again, there was a concept where, there was a time when people used to take up every case for fenestration.
Yeah.
Now, fenestration is nothing but making a slit in the nerve sheath.
Yeah.
Now, the thing is that now we should know where exactly we place our fenestration. So again, as I told you about the anatomy of the optic nerve canal, along with the optic nerve, you have the ophthalmic artery also, which passes through that.
Yeah.
And the most common location of this ophthalmic artery is inferior and lateral to the optic nerve. In the sense, when you go from an endonasal corridor, the optic nerve is slightly away. Now it depends on which side you are dealing with. For example, if I were to tell you that we are in the left nasal cavity, so just imagine it from an endoscopic perspective.
Yeah, yeah.
If I'm in the left nasal cavity, I open up the sphenoid and I see the optic nerve. So it is inferior and lateral to the sphenoid. So roughly it comes at, I would say, the 4 o'clock position or somewhere around that area. So if you have to make a fenestration in the left, on the left optic nerve, your preferred location would be between the 12 and the 3 o'clock. Understand? So you don't go into the lower quadrant, because that is where you have a chance of hitting the artery. Whereas in the right side, roughly the location of the artery would be at the 7 o'clock position.
Yeah.
So the area where you would like to make your sheath incision would be between the 9 and the 12 o'clock position.
Okay.
So in an area away. So again, the principle is you'll have to slit through the sheath all the way till the level of the annulus. So I showed you how the annulus is seen right at the apex, and from there, so you bring on that incision all the way to the annulus, so that it actually kind of relieves that strangulation. Now the problem here is, within this sheath, usually there is CSF around the optic nerve, because this is actually a continuation.
Yes.
It's actually the layers of the dura which kind of blend and forms this covering around the optic nerve. So once you incise the sheath, you may see an egress of CSF leak. So that is why I said, now this is probably an indication if you have a swollen nerve, if the nerve looks very swollen once you remove all the bony fragments, or if you have a classical hematoma. In those cases, yes. But otherwise, we generally don't, because you are again opening up and probably ending up with or causing a CSF leak per se.
Yes.
And again, if you see the literature does not support it routinely, the evidence is very weak.
Yeah.
So that is why we don't advocate it routinely. Yeah. So that is about fenestration as well.
Okay. Excellent. Yeah.
So I'd be happy to take up any other questions.
Yeah. There are a few questions, Dr. Vivek. The one is Danya ma'am is asking, so what is the dose of steroids you're using? What's your protocol?
Yeah, so now the thing is, steroids for that matter, I think as far as ENTs are concerned, we only know one dosing, that is 1 milligram per kg body weight.
Yes.
So that is what we generally recommend. But then again, the thing is that these patients are not under us most of the times. I would say 99% of the times, these are not our patients. These are neurosurgical patients.
Okay.
For some reason, I think the neurosurgeons have a protocol where they generally resort to high dose. What they refer is as a mega dose steroid therapy, that is with prednisolone.
Yes.
So, so this is in line with generally most of what most of the neurosurgeons follow is something that is advocated with the national spinal cord injury protocols.
Yes.
So where they recommend methylprednisolone in high doses. So it's usually 30 milligram per kg body weight as loading dose into the first 24 hours. Subsequently, I think they bring it down to around 5.4 milligram per kg body weight. But then ultimately the carry home message is some form of some steroids. Yeah, I mean, whatever dose according to that protocol has to be followed. I mean, whatever is the molecule, the adequate dosing according to that. So I think there will be institutional variations for sure.
Yeah. So you give oral steroids preferably in your product, this thing. Prednisolone.
That's what I'm saying. Prednisolone is a safe bet because that is something that works for most of the nerve injuries, right? That is what I was talking about, because it is not the ENT surgeon's call per se, because most of these patients in our setup, most of the patients are started on methylprednisolone by the neurosurgeons. So we
They would have started before coming itself.
Yeah, even before we see, they would have started.
That's true. Yeah. Even, I mean, more or less, we have the same protocol here. Many a times, neurosurgeons, they call us in. Yeah, that's right.
Yeah.
Okay, so this is in a decreasing dose, right?
Yeah. This, so even if we continue that, even if we take up the patients, we do continue with the steroids.
Yeah. Right. Yes. Then, ma'am, I hope that satisfies your answer. That will be in a decreasing dosage. Okay.
Yeah.
Yeah. And we have one more question. That is how to preserve ophthalmic artery.
So I think that is again based on the location. So I told you the specific location. It depends on which side. Now, ophthalmic artery generally will not come into your picture. Now, that is only a concern if you're dealing with, if you intend to make a fenestration.
Okay.
Otherwise, no.
Okay.
That I think we have already described. Right side.
Yes. You're right.
If you take the clock into consideration, what is the position? Left, what is the position?
Yes.
Remember, it is inferior lateral.
Okay. Hope so that satisfies Dr. Hitesh Patel. This thing, a good friend of mine. Okay, now one more question. What are the essential instruments one should have during decompression?
Decompression, essential instruments, your routine endoscopic sinus surgery instruments.
Yeah.
Okay. Plus, apart from that, now as you go deep, as you start working along the optic nerve, now remember, in these kind of patients, you have to be very careful when you use your powered instrumentation, especially the debrider. Now, what can happen is sometimes you can have glyosed brain tissue. We have seen sometimes there is herniated brain tissue coming into the field. You would be using a debrider without knowing what exactly it is, because everything gets sucked in.
Yes.
So be careful when you use these powered instruments. That is one. Two,
Okay.
you may require drills. I did show you what scenario when sometimes you may not be able to mobilize a bony spicule which has a broad attachment or which is thick. So in those kind of cases, under low speed, you'll have to drill. Now, three, when it comes to elevation, most of the times what we are used to is your Freer's elevator or your Cortils elevator. Now, what happens is that the optic nerve classically is not a straight structure, in the sense the optic nerve does not take off in a straight line from the orbital apex.
Yes.
It is something which is angulated. It's something like a takeoff, like how a plane takes off from the runway, from the orbital apex, it takes up slightly superiorly as it goes posteriorly. So it has a slight superior slant as it goes. It comes medially and goes intracranially.
Yes.
Now, many times what happens is that now your conventional instruments, your straight instruments, sometimes you'll have difficulty working above the optic nerve, below the optic nerve. So you have these nerve hooks or retractors which come with neurosurgeons.
Okay.
That is something like your, I would say something like a ball probe, but then the tip does not have that ball, just the curve.
Okay.
With that, you can actually gently elevate the bony spicules. Apart from that, I told you round knife, flag knife, sickle knife. These are fine instruments. You can use your pick to manipulate the bony spicules rather than pulling. So you'll have to dissect all around.
Okay.
Because big instruments don't fit into that small crevices. Like now, for example, you are working in that optico-carotid recess or the supraoptic recess. No, you'll have to have finer tipped instruments.
Okay.
Yeah.
Yeah, perfect. So what do you use for this thing, incising the sheath?
Yeah, incising the sheath. Now you have a couple of options. Now, one concern is, you should be very careful when you incise the sheath. You shouldn't actually the instrument should not go on to the nerve.
Yeah.
Now, that is one of the disadvantages when you use, now it is not like your facial nerve. Now, facial nerve can withstand that kind of a minimal little bit of, tears or injuries, the facial nerve will recover or it can tolerate. Now, optic nerve will not tolerate. Now, something that we should understand is that the optic nerve does not have the ability to regenerate.
Yeah.
Now, I am sure sir would probably remember the days when people spoke about stem cell therapy in optic nerve.
Oh, yes. Even now.
But then where is it?
Yeah.
So
some people still advocate it,
that is again the difference, sir. Now that is again the difference because the facial nerve can regenerate.
Yeah. But not the optic nerve.
You keep a graft in between if you expect things to grow over it.
Yes.
You expect the fibers to grow over it.
Yes.
You can't cut the optic nerve and keep a graft there.
True. So you cannot do any cable grafting also.
You can't do any cable grafting. Now the thing is why? Because it does not regenerate.
Yes.
Now the thing is that so even if you damage one of the fibers, you are causing damage there.
True.
So now, although you say that when you do facial nerve decompression, use a sharp instrument and make your sheath incision, I would not be all that bold to do that with a optic nerve.
Yeah.
So I would say probably those kind of situations. We use blades. You can use your 11, you can use your 12, but then again you have to be careful that you don't go too deep in. But then I would be happy with a sickle.
Okay.
The reason being because most of the times the Indian sickles with use they turn to be blunt, so that is a blessing in disguise, I guess.
Yeah, they're not sharp.
Yeah, so they are not all that sharp, but they are sharp.
Yeah, sharp enough to cut the thing.
Yeah, so I think
that's
what I am happy with.
Yeah. Fair enough.
Again, the important thing is if you're using sharp instruments is not to keep the knife or the blade perpendicular and cut through.
Yeah.
You have to just keep it in a slanted way and just make a small incision and then extend that with some other instrument.
Yeah, rather it has to be parallel.
Yeah,
parallel to the sheet.
Absolutely.
Yeah. I agree with you. Yeah. Anyway, I didn't have an opportunity to do that so far. Actually, the largest series we had was from Al-Shifa Hospital, Pentalman only. Long back in 18 years, in 4 years, we had about 18 cases which had presented in the Skull Base conference in 2001, which was held at Mumbai. Okay. After that, after coming back from Pentalman here, I used to take care of complete facial maxillary trauma there.
Okay.
That's how I used to get a lot of cases. But after living parental
Because
manna, we don't
the-
see so many cases here.
no, the
Rather, cases are
subset,
missed.
yeah,
Cases are missed.
that is
Yeah,
very common.
yeah,
No,
I
the
know,
thing is
I know.
that these kind of cases come only in a center which deals with facial-maxillary trauma.
Yeah,
And secondly, where you have a full-time neurosurgeon. Otherwise, generally, it is not something that you
yes,
come
yes,
across in any other setup.
yeah,
So because it is not usually a single entity, as I told you, it's usually these patients will have multiple problems. So unless and until you are able to deal with everything,
yes.
so you will not be seeing these patients.
Yeah, yeah. So I noticed some of our consultants and even residents, they fail to examine the vision or even at least look at the reflex if too
Absolutely.
much lid edema and eyelid edema and this thing is there, hematoma,
Yeah, absolutely. No,
Yeah,
because
yeah, they
you
fail
will not be
to,
able to assess the no. The thing is that you can always retract the lid and just flash a torch.
yes, yes. That's a basic minimum one should do.
Absolutely.
Yeah, yeah. Yeah. We have a pro forma where that must be done so that that I
I
prepared a
think
pro forma so that people don't miss it.
no,
Yeah.
I think all residents should be taught how to do a
Yes.
swinging flashlight test. So that is
Mhm.
the basic thing.
Yeah.
Because normally when you flash the light and just have a look, the pupils will constrict.
Yeah.
But you
Yeah.
have to do a swinging flashlight to pick up
Yeah.
if there is an injury or not. Otherwise, you will miss out.
Yeah. We have Dr. Rajani from Madurai. They have done, I believe, 44 cases. Rajani, you have any difference of opinion or anything you want to share today? You can unmute yourself. Where are you, Rajni? Yeah, you are here. Okay. Rajni is a good colleague of mine, good friend of mine. Yeah, Rajni, how are you? Nice,
So
nice
I'm
that you
fine, sir.
joined
How are
in
you,
today.
sir? Sir,
Thank you
nice
very much
talking
for
to you.
joining. Yeah.
Okay, sir. Okay, sir.
You
So
have
still
any?
we have largest serious bubblies also, but still we are practicing because in institute, in private practice, still we are practicing these cases.
Okay.
But outcome only we are very scared, sir, because even recently we have operated monthly. I used to operate one cases at least minimum 1 to 2 cases traumatic optic neuropathy.
Okay.
But what Vivek doctor said, we have standard protocol. We used to start high dose methylprednisolone, 30 milligram per
Okay.
kg. Sir, that is the standard
Okay.
protocol. We usually start
How long that is
approximately
given?
one.
How long?
Minimum 3 days, sir. On the 1
Okay,
gram
three
is a
days. Yeah.
standard day.
Uh-huh.
So we used to give 50 milligram per kg, 50 milligram BD. That is the
Okay.
protocol. So 30
Okay.
milligram per kg, that calculation comes correct only.
Mm-hmm.
But initially, that poor prognosis, patient with vision loss, total vision loss, whatever you operate, we have done a larger series of decompression.
Mm-hmm.
So what you said, like facial now, that optic now is very different, sir.
Yeah. Yeah.
The outcome
Yeah.
is even facial now, it has a good chance of recovery. Optic now, after a decompression, it should come immediately or at least 4 weeks. Once after 4 weeks, even the optic nose goes for atrophy. The vision will not come
True.
after 4 to
True.
6 weeks.
True.
Around this,
True.
visions come immediately or within 4 weeks.
Yeah. Yeah.
So this
Yeah.
is standard protocol. We are admitting and starting steroids simultaneously. We do optic for decompression, maybe 1 or 2 days, and we give 3 days to 5 days of methylprednisolone, and we taper to oral drugs around that.
Okay.
Surgically, we do complete optic decompression. We remove
Mm-hmm.
the bony canal, medial, and the inferior also we remove. And
Okay.
during traumatic cases, there is a controversy whether to do a optic nerve sheath fenestration or that is the only thing. But usually with bony decompression may be sufficient. But in case of idiopathic intracranial hypertension, we used to do some cases.
Okay.
That case, we have to open the optic nerve sheath fenestration. So traumatic, we usually do a decompression. In our few cases, we do a sheath incision.
I
That
But
is
think
the
is
difference.
you said inferior wall also, but more than 180-degree decompression, is it possible, practicable? Because optic nerve has such a close relationship with the internal carotid artery.
Okay.
Is it possible to do more than 180-degree?
Well, I didn't understand your question, sir.
You said not only medial wall, you said even the inferior wall is decompressed.
Yes, sir. Yes, sir.
Yeah,
So
but it
usually
has
we
such a
can do completely. We can do a medial wall. Inferior minimal we can open, sir.
okay,
So if
minimal.
only
Yeah, yeah.
can.
Okay. Yeah, yeah.
Sometimes we are able to do 360-degree rotation. We can sometimes
Yeah,
some cases we
sometimes
can
when
achieve.
it has a decent
We
root
will
in
not
the
do bony
yeah.
canal. We can do only the medial inferior, but we can
Yes, yes.
release the nerve, sir. That much we
Yeah,
have
yeah,
still right
yeah.
now.
Agree with
So
you.
up to optic chiasma, like we can decompression that is
Yeah,
possible.
yeah.
So with the
Agree.
micro these things but only thing when you take in private practice that we have to explain the patient the outcome. We cannot give 100% guarantee that will bring back the vision. So basically, the outcome of vision after decompression, we have to give a guarded prognosis only. Then only we have to take up a surgery.
Yeah.
Because based on clinical experience, we have done even within 3 days, the outcome will be better, sir. Within 7 days, 3 to 7 days, the outcome will be around 50%. If you take case after 7 days after decompression, the outcome will be around 30% only. So, but this is our CDS, but practically we are operating now, but still that outcome is we are not expecting too much decompression after surgery.
No,
So even though we are,
yes,
we are doing surgical decompression, steroids. So Optic now is something different. It's working, sir. And even what Dr. Vivek said, stem cell therapy, whatever thing is there, but outcome is should we give a guarded prognosis?
Yeah, that is something is very important. The consent and guarded prognosis is very important. That's the thing.
Can I add?
So Vivek, you believe in this golden hour. I think it's better to be done within 24 or 48 hours. Or is it okay to do? Till when we can still go ahead and do it, Optic now?
If you have an obvious, what do you call, radiological evidence with obvious signs, you have to actually, now the issue here is actually once you pick this up, now you tell the patient relatives, you explain the situation to the patient relatives. Now the problem is that the general condition of the patient may not permit a surgery.
Yes.
So now the question is, would you like to decompress a patient who has a score of maybe 3, a GCS score of 3 on ventilator? Now, is that the focus? That is the whole issue here.
Yeah.
Secondly, in our Indian scenario, now you have to prime these patients. Now, day one, when you see your suspect, now you have to actually tell them that this is a thing what we see. So if things don't improve in the next few hours, that is in the subsequent hours, then probably we may consider. Because here now in India, what we generally say, I don't know how it is in your place, sir, but at least in Kerala, now they'll have to get consent from umpteen number of people. Now they'll be.
I know. I agree with you.
So now the thing is that
I've gone through that. Yeah.
The golden hour becomes a bronze hour.
Yeah.
So now, so the thing is that if you start priming them or give them a hint that we may have to consider, so they are at least kind of ready to take a decision by after 48 hours. Now the thing is that you tell them after 48 hours, they'll take another 48 hours to take a decision.
True. That opportunity will be lost.
Yeah, so I think the minute we see, we always tell them that this is it. Now, and forwarding, if the general condition of the patient permits, you would take it upward.
Yeah.
If you have a significant displacement.
Sure.
And I think one of the points that doctor mentioned about optic nerve fenestration. Now the whole concept in benign intracranial hypertension is totally different from what we see in traumatic optic neuropathy.
Yes.
There the compression comes from within. Why? Because the CSF pressures are high, so that pressure gets transmitted to the optic nerve. That is why you are slitting the sheath to relieve that pressure. Hello?
Yes. Yeah.
So that mechanism is totally different.
Can I add something, sir?
Yeah. Go ahead.
No, sir. The indication, earliest indication, if you see, sir, on the patient with the complete vision, it's definitely we can consider as earliest. We will not wait for steroids, sir. So three things is that one is a clinical. Any patient with complete vision loss, we would advise some earliest surgery. Second, radiological evidence of bony fracture in the optic canal. Optic tubercle, that is definitely indication you have to go for decompression at the earliest.
Yeah.
Previously, when you are having an institute, you have a luxury of visual level potential. The absence of potential is itself, you have to go for earliest indication. But usually, this thing takes more time. Before most of the cases, maybe it can be a polytrauma, simple trauma, optic no injury. So even patients have minor injury, they go in the bike, skid from the bike, they get injury in the forehead, just in the roof of orbit.
Yeah.
They have minor or a small incision, scar injury that will be there, but they will be losing the vision. So patient can be multi-trauma or a minor trauma can be there. So this patient, most of the patient, what I get initially is that this is a minor trauma patient. They go in a bike, they skid somewhere, then hit the forehead, and they'll be conscious oriented within 24 hours, but they have complete vision loss. So these patients, if you subject them for earliest decompression, but the patient usually the problem is the prognosis. So we cannot give 100% guarantee, but we can give a guarded prognosis. But if you earliest, the best treatment, steroid and decompression give you a good outcome. So these are three indications. One is that complete vision loss, CT evidence of optic canal fracture. If you have luxury of visual evoked potential, absent potential is an indication for earliest intervention, sir.
You agree with you,
So,
but
coming to the
actually
optic
what we were
fenestration,
discussing was the practical problem with patient consent. I think that was a major concern what Dr. Vivek was mentioning. See, we can't rush into operation theater unless patient gives consent, isn't it? Patient relatives, this thing. I mean, you wouldn't rush the patient to theater without the consent, right?
definitely, sir.
Yeah, that becomes a limitation. I know.
What is the difference between the government institute and private institute? Means they're going to operate free of charges, so the patient doesn't matter. They will give consent at the earliest.
Yes.
So in giving a private practice, you have to the financially patient has to be affordable. They have to think twice, spending money.
No, that is those are the, see, in India, those are the practical problems we have with the consent and other things, you know. And also, forget consent of the patients and their relatives. Sometimes we also need consent of our colleagues, ophthalmology colleagues, neurosurgeon colleagues.
Ophthalmologist also.
Yeah, see, they may have a different of opinion, you know.
Very
yeah, what do you say, Dr.
Absolutely, I absolutely agree, because I remember, when you start these kind of things or when you come up with something different, there will always be resistance before you get that acceptance.
That is the point. See, we have lots of overlaps here, you know, these fields.
Yeah, absolutely.
When there are a lot of overlaps existing, you know, with the different specialities, you also need their coherence, you know, their help, because, I would like, even though if I identify the optic nerve injury and I know that this patient immediately needs optic nerve decompression, I think without ophthalmology consultation and his notes on the paper, I wouldn't trust the patient to OT. What do you say? You agree with me?
Absolutely. Without documentation, no point. Now the thing is,
no point.
If patient is comatose, at least a endoscopic examination might.
We should have their opinion. We should have this thing on the paper, okay, on the documentation. That is very important, you know.
Because again, sir, regarding the consent part, right now, that is again something that is always a problem here. Because now, to me, any optic nerve injury, now to start with, I just give it a 50% chance.
Yeah.
Okay, but now what are the things that actually go through my mind? Now, if the patient is a conscious patient, now if the patient has loss of vision, if there is perception of light, that is a positive sign to me.
Yes.
If there is no perception of light, that is again poor prognosis. So from 50, that outcomes keep dropping down.
Yes.
Now, second scenario is now intraop.
Yeah.
Now, intraop, when I go in, now if I see a case like the first case that I showed where there is impingement, where it is pierced, then again my prognosis still keeps dropping down.
Yes.
Whereas if it is just an extrinsic compression where there is a fracture, but that entire covering nerve looks healthy, I'm happy.
Yeah.
But now the thing is, these are things which come through my mind.
Yeah.
But then when I counsel the patient, I would just probably say it is like less than 10% chance that it may come back.
Yeah. Now, very important. Anyway, this is optic nerve injury requires a teamwork. You know, we should have a consent of and cooperation of our colleagues, neurosurgery as ophthalmology colleagues. I think that goes without saying, you know.
Absolutely.
That we must do. Okay, friends, any other questions? We had a fantastic discussion on this topic. You know, I thought this is a small topic. We may be able to finish in less than an hour, but you know, we are already nearing 2 hours now. Okay. Yeah, fantastic. No, that's how some of these topics, when we have passionate people like we have passionate people like Dr. Vivek or Dr. Rajani around us, you know, this is how the science grows, you know, how we get into the depth of the science, bottom of the science for that matter. Thank you very much. Friends, if any other questions, please, you can raise your hand, or you can even, type in this thing from Dr. Rajiv. Thank you. So a lot of appreciation from, a lot of colleagues, Dr. Hitesh and Dr. Rajiv and Dr. Ravi Kishore and all the friends, Dr. Anandita from Guwahati, and a lot of friends, a lot of appreciation. Thank you very much, Dr. Vivek. That was a wonderful presentation, wonderful insight, and the great work you're doing, and you're touching lives of many patients. I would love to have you back on this platform again with a different topic and a different date. Thank you very much for sharing your date. You know, we had a small audience, but we had a very quality audience. That's what is important. When our message gets conveyed and they start practicing, and they remember your golden words, whatever you said today, and that will go in long way, in growing their lives and as well as their patients. Okay. Thank you very much, Dr. Vivek, for
Rishabh,
your
thank you
time.
so much
And
for
thank
this
you all,
great
friends.
session.
Thank you very much
Yeah,
for your
hope to
time.
see you.
And,
Thank
you
you,
have
sir.
been, many of you have been, attending our programs so regularly, religiously. We are touched. This is you people motivate us to do these programs, more and more programs. So in future, we will be coming out with even more innovative programs. Please be with us. Thank you all. Thank you, Dr. Vivek. Good night. Yeah.
Thank you, sir.
Thank
Bye
you.
bye.
Okay.